Hello listeners, welcome to the third video in our series of common NCLEX traps and how to avoid them. My name is Anne. I am an NCLEX success strategist with VPNG NCLEX Academy. And today for the third common NCLEX trap, we're going to be discussing the Hemoconcentration Lab Trap. If you do not know, in this series, we are breaking down the exact traps that NCLEX likes to set, and the ones that cause high-performing students to miss questions that you do usually understand, because if you can spot the trap, you can beat the question. So you might want to look through the channel and study or listen to the other traps we've discussed and take note of them when you attempt question banks and see how they improve your score. On to today's trap, the Hemoconcentration Lab Trap. Now, before NCLEX turns this into a trap, let's try to understand the biology. Hemoconcentration happens when plasma volume decreases while red blood cells and solutes remain, right? So the blood becomes thicker, not because the body produced more cells, but because it lost fluid. This mostly commonly occurs in severe dehydration, vomiting and diarrhea, burns, hemorrhage, excessive diuresis, third spacing, and when fluid leaves the vascular space, several things happen simultaneously. What are these things? Circulating volume drops, perfusion decreases, kidneys activate compensation through RAS, of course, ADH increases water retention, heart rate increases to maintain cardiac output. Meanwhile, the laboratory values begin to shift, not because the disease is worsening, but because concentration is changing. What you are seeing is the body trying to survive, and NCLEX is testing if you can recognize that survival mechanism. Why does NCLEX like this trap? Because NCLEX is a safety exam. Hypovolemia progresses to shock progresses to organ failure leads to death. So hemoconcentration is an early clue. And the exam, NCLEX does not present it dramatically. It could give you hints, quietly. You could see a slightly elevated BUN, a high normal hematocrit, a concentrated urine specific gravity. You could see mild tachycardia. You could see dry mucous membranes. Nothing looks catastrophic, right? And that exactly is where the trap is. If you want to observe, consider your stem or your scenario. You would usually find fluid loss. They'll tell you the patient has vomited for 2 days. They had profuse diarrhea. They experienced burns. They had poor oral intake. They used diuretics, things that result in fluid loss. And then the labs are presented. And this is where a lot of candidates fall into 3 major cognitive errors. Error 1, you could be treating the numbers as independent. Some candidates often look at each lab separately. High BUN, maybe kidney failure. High hematocrit, maybe polycythemia, right? Elevated sodium, maybe hyponatremia disorder. But NCLEX is not testing isolated lab memorization. NCLEX needs to see your ability to recognize patterns. So when the fluid is lost, everything inside the bloodstream becomes more concentrated. There's less plasma, less cells, less plasma, same cells, same solutes, higher numbers. The second error is waiting for blood pressure to drop. Many candidates wait for hypotension before they act, but hypotension is a late sign. Why? Because the body compensates first. You would see heart rate rising, peripheral vasoconstriction occurs, urine output drops, renin-angiotensin activates. By the time blood pressure falls significantly, perfusion is already compromised, and NCLEX knows this. That is why the exam will often show you normal or borderline blood pressure to see if you can recognize the earlier deterioration. What's the third error? Misinterpreting high hematocrit. Now, high hematocrit in dehydration is not increased red cell production. It is concentration. The red cells are the same number. There's just less fluid around them. So students sometimes anchor on hematologic disorders and miss the simple explanation, which is volume loss. So what is actually dangerous in this scenario? The real threat is not necessarily the lab abnormality. Hypoperfusion is the real threat, because when circulating volume drops, the kidneys receive less blood flow, blood perfusion decreases, cardiac output falls, lactic acid begins to rise. Unchecked hypovolemia leads to hypovolemic shock, and the labs are early warning signs. And NCLEX could describe you by asking you to administer diuretics or restrict fluids, or focus on electrolyte replacement only, or monitoring without intervention, or treating a single lab values. These options are not irrational. They make sense, but they are not complete. Remember, NCLEX is not asking you what looks reasonable. NCLEX is asking you what could stop the most drastic effect of what the stem has presented to you. In this case, it's asking you what will prevent shock. So how do you recognize the trap? Just to recap, if you see fluid loss in your stem, if you see vomiting, diarrhea, burns, bleeding, poor intake with weakness, dry skin, tachycardia, decreased urine output, then you look at the labs. If BUN rises, if hematocrit rises, if if urine specific gravity rises, if sodium trends upwards, you are not looking at organ failure. What you are seeing is hemoconcentration, and hemoconcentration means volume depletion. Okay, the intervention that reverses the threat is fluid replacement, not slowly, directly. And isotonic fluids restore circulating volumes. Okay, restored volume improves perfusion, and what improves perfusion prevents shock. That's why this is your priority. Everything else that you can possibly do is secondary. What if you're unsure? You look at the scenario, you suspect this, but you're unsure. How do you make an accurate guess? Ask yourself one question. What is killing this patient first? What is the most acute threat? Is it the elevated BUN? No. Is it the hematocrit number? No. It is reduced perfusion. Then ask yourself, what option restores perfusion the fastest? The answer is almost always fluid resuscitation. When in doubt, correct circulation before correcting numbers. NGN NCLEX might make this more layered. You may see multiple lab trends over time. You may see Q clusters combining vitals and labs. You may see a bow-tie question requiring identification of the condition, action, and monitoring. The exam may just show you a patient deteriorating gradually. Your job is to detect the shift from compensation to decompensation. Remember, compensation masks severity, but the labs will reveal it early. So pay attention. As a regular process in deciding your NCLEX question, you have to prioritize airway, breathing, circulation, sepsis, electrical instability, hemorrhage. Remember, and hemoconcentration is a circulation issue. And circulation attracts comfort, education, chronic disease management, routine monitoring. This is why fluids win. If you have to pick an option, remember, if fluid leaves the body, lab values rise. Don't go after the numbers, go after the physiology. Because elevated labs and dehydration, they are not a kidney problem first, they are a volume problem. And volume problems become shock problems. So you need to be able to recognize this early, correct it decisively, and then you can move to your next question confidently. If you have, if you found this helpful, imagine learning every system this way, organized by question bank patterns and possible ways that NCLEX is trying to trap you. So at VPNG NCLEX Academy, we are not just reviewing content. We train you to recognize traps, prioritize like NCLEX expects you to, and think in safety hierarchies. You can join our lectures for as little as $20 monthly. The best part is that with us, you can pass NCLEX in 90 days. We have spaced repetitions, recurring tests that help you remember what we learned as early as day one. So if you're serious about passing NCLEX and passing NCLEX the first time, give us 3 months. Visit our website, vpngglobal@gmail.com, or you can send us an email, contact@vpngglobal.com. See you in the next video.